So today we're going to be joined by Dr. Mohammed Mputu, who's going to take us through a very interesting topic, the clinical radiological diagnosis of TB. So this is going to be about bridging the clinical insights with imaging techniques. And it's going to be exciting to see what we can gather from here. So, pardon me. Today we're going to be joined by our panel of experts. We have Dr. Chitalu Chanda, we have Dr. Linus Mwinga, Dr. Ntini, Dr. Kenneth Kapolowe, who will be joining us on the panel, and you're all very welcome. Just a few house rules before we get started. Kindly ensure your microphone is on mute. If you do have any questions, kindly raise your hands or post in the chat box, and then we shall be able to attend to them. At this point of time, so we're just waiting for Dr. Mputu to join in. He just dropped out. So I'll just give him a few minutes.
Hi, Neil, I'm here.
Okay. Hi, Dr. Mputu. Okay. So once again, Dr. Mputu, thank you so much for joining us, and I'm gonna hand over to you now. Dr.
Hi,
Mputu?
I'm here. Please, this is in a formal day?
Yes.
Okay. Hi, good afternoon, network. Thanks once again to the Echo Hub team for the invitation. It's been a while on this platform. I think it's been a few months I haven't been here as a presenter. So could you go to the, we'll discuss issues to do with clinical diagnosis of TB. I'm going to concentrate mostly on what most people use to make a diagnosis of TB, chest X-ray. Of course, there are other imaging modalities that I'll just mention in passing because most of us don't use that. So I'll just I've paid attention on the what. And my approach is a bit different this time because I want to make you all aware of the wide variety of diseases that can present as TB on X-ray. So you recognize some pitfalls where that is concerned. I've added one or two clinical cases just to stimulate your thoughts over those two cases. So first case is about a 39-year-old female. By the way, this is a real case. This is a 39-year-old female who had presented with 1 year history of chest pains and weight loss. She was HIV negative, and she had no non-TB contact, and her past medical history was only significant for having treated for COVID-19 during one of the waves. So the question to you all is, if you look at this X-ray that was done about this patient, do you people think in the network, do you think this patient had TB or not? So if you look at this X-ray, I think this is supposed to be a poll question for people to vote. Yeah.
Great, thank you, Dr. Mputu. So, yeah, we've got that history, a 39-year-old female with a 1 year history of chest pains and weight loss. She's HIV negative, has no TB contact, but has a past medical history significant for COVID-19. So from that X-ray, do we think this patient may have TB, yes or no? So let's all try participate in this poll question. Remember, your answers remain anonymous, and we're all here to learn. So kindly ensure you all participate in the poll questions. Okay, very good. It's a good response so far. Let's all continue participating. Shall be ending the poll soon. Okay. All right, great. So I'm going to end the poll here now. So Dr. Mputu, we've got very interesting answers. It's almost a 50-50 situation. About 47% have opted for yes and 53% for no. So I'm sure we'll learn more. Over to you from this case.
Oh, thanks. Yeah, these are interesting statistics. They almost match the same statistic seen at the national level where clinical diagnosis is concerned. The percentage of people diagnosed with clinical TB almost is reflected in this same poll. If you can go to the next slide. So this is another clinical case, another real clinical case. This is a female 39 who had been treated for TB 3 years before the current presentation. She had presented with history of a cough for 10 days and a history of a productive sputum production for 7 days and a history of chest pain for 4 days. I forgot to indicate that she also had a fever at this. She had also admitted to having a fever. Other past medical history, other than the fact that she has been treated for TB in the past, was the fact that she had the HIV on treatment since 2010. So the question again is, if you look at this X-ray, do you think this patient has TB or not?
Great. So we've got that short history, female 39 with a 10-day history of cough, fever, 7 days of sputum, and 4 days of chest pains, and had one episode of TB 3 years prior. Is HIV positive since 2010? Is this TB? Yes or no? Again, very interesting answers, and I love that the network is participating. This is great. Let's all make sure we continue participating. So 39-year-old female, 10 days history of a cough, 7 days sputum production, has fevers, 4 days of chest pains, one TB episode 3 years prior, and has been HIV positive since 2010. Is this TB? Could this be TB? Yes or no? Okay, so I'm going to end the poll question now and sharing with you, Dr. Mputu, we've got 87%. They've opted for option A being yes. This is TB or could be TB, and 13% that opted for option B saying no. Again, very interesting, and over to you.
Yeah, it's very interesting. It would be very nice to ask one of those people who have said no, why they thought this was not TB, and maybe one from those who said this was TB, and to see their argument. Maybe at that point we can allow people to say why they thought this was TB. Someone can also say why they thought this was not TB. We can go to.
Okay. Okay.
So most of us, I'm not going to bore you with the usual symptoms of TB, of cough, what, because most of us are easily aware of these symptoms because we've got a lot of tools. In fact, screening tools tend to capture most of these things. But as a whole, from the clinical setting, most patients will come with either pulmonary TB or extrapulmonary TB. This is very well known for most of them. Examples of patients who come with the pulmonary TB are patients who have productive cough. And these are the majority of patients who have respiratory symptoms. Extrapulmonary TB patients may present with lymphadenopathy. Commonly, these are cervical lymph nodes, pleural effusions, or spinal TB or TB meningitis. But this is just a limited list. In fact, it's very good to remember that TB is essentially can affect every organ system that you can think of on the body. So some of this, in the past I've mentioned that some of these are skin rashes that people see. Some of these recurrent UTI that people treat. Some of these ear infections, eye infection could just be TB. So the key here is to just remember that TB has a different ways of presentation. In the pediatric age and those who have HIV-associated TB, they may have atypical presentations, or they may present with the minimum pulmonary findings. But we also see majority of them tend to present with the more of disseminated TB disease, especially those of you who work at very advanced health centers like provincial district hospitals may appreciate most of these patients that you have TB tend to be admitted for a while in the hospital because they've got disseminated disease. So this again brings a lot of challenges when we are waking up these patients, especially that after you do your ordinary tests like sputum, and some of these, majority of these patients will tend to have negative sputums, and in many instances, the patients may not have time to wait for sputum culture results to come back so that whether to confirm whether there's TB or not, because this usually takes 6 to 8 weeks before you see any result. So most clinicians, most of you are usually pressed to make a decision as quickly as possible about the patient, if the patient is admitted with the pleural effusion, or the patient is admitted with the headache, we are evaluating patient for TB meningitis. So the decision has to be made whether this patient has TB or not. And usually, the majority of patients will have been exposed to the initial imaging, which is the chest X-ray. So this is where I think I'm going to focus our discussion because most of you are experienced with the chest X-ray, but don't seem to. I need you to appreciate the vast way diseases can present on X-ray similar to TB. Next slide. Yeah. So like I'm mentioning, when we are using chest X-ray as a diagnostic challenges, we have to take into consideration the wide differential diagnosis of abnormalities on chest X-ray, and the fact that chest X-ray does not necessarily exclude, normal chest X-ray does not necessarily exclude TB. And again here, it will be important to mention that WHO actually encourages the use of a chest X-ray as a diagnostic tool rather than an independent, as it encourages the use of chest X-ray as a screening tool rather than an independent chest X-ray diagnostic tool, other than an independent diagnostic tool. For example, the way we can use sputum to make a diagnosis of TB once it's confirmed is different when we are applying the use of X-ray, because we are taking a lot of factors into consideration. And these factors, most of them stem from the differential diagnosis of TB, which I'll walk you through now. Next slide. So on X-ray, unfortunately, these are remade slides. The original slides that I had made, I've left my laptop somewhere. So these I made them quickly. So I've not added the images that I had to show you some of these imaging findings. But in the previous slides, in previous presentation on this same platform, there's been some presentation that has shown the different ways TB presents on chest X-ray. So you'll forgive me for that. But I can describe some of these common findings on X-ray. These commonly you find infiltrations or cavitations usually affecting the upper lobes. Okay, and classically TB is described as the cavitation in the upper lobe, like classic TB, and so most people would think TB once they see that kind of abnormalities. So if you show any experienced clinician, from especially those who are practicing the 80s and 70s and early 90s, and you show them an abnormal cavity in the upper lobe, they will tell you this is TB because of this. That's how classical TB presents. But this does not necessarily mean it's TB. So we can still find pneumonia. We can also still think about pneumonia as differential, for example, caused by Staphylococcus aureus, Klebsiella pneumonia, fungal infections like histoplasmosis, aspergillosis, and cryptococcus itself. For those who may not aware that cryptococcus also as a pulmonary presentation rather than just the classic thing that we look for in terms of TB, in terms of meningitis. So some patients actually do have respiratory symptoms, and it's cryptococcus. Those who are very sick patients, those who are admitted in the wards and have got septic, it can be due to septic emboli. Abscesses can also present in the same way. Granulomatosis with the polyangiitis is a very interesting renal disease. Actually, we call it renal pulmonary syndrome, where patients come with the pulmonary infiltrates and kidney failure. So when you look at the pulmonary infiltrate, they will have a history of hemoptysis, abnormal chest X-ray, but the creatinine is very high. So this is how the patients tend to present, who have what we call in short GPA. Also, patients who have lung malignancies can also present like this. So these are the diagnoses that you start thinking about when you see such patients. Next slide, please. So this is one way the TB can be present. So the common way most of you may be familiar is the miliary picture on chest X-ray, and those of us who've been in medical school, we used to be told that there are more than 10 differential diagnoses for miliary picture. Miliary picture does not always equate to TB. If it's TB, it usually suggests a very advanced disease because this is a very sick patient who has miliary TB. So miliary TB has a number of differential diagnoses as well. Not exhaustive list, but I've just tried to put the most common things that can present as miliary TB. This includes disseminated fungal infections like histoplasmosis, coccidomycosis. Of course, some of these diagnoses will only confirm bacteriologically if you send the relevant samples for testing. Viral pneumonias like varicella pneumonia are probably common in HIV positive people. Pneumoconiosis, like patients who've been working in mines. So this should be some of the, those of you who work from the copper belt, this is one of the common differentials you should be considering when someone comes with an abnormal X-ray, because most people there have either current miners or have worked in a mine before. Sarcoidosis is also another differential, very typical in a younger age group. And again, this is the same age group that you find most people have TB, but this is also the same group that people have sarcoidosis tend also to present. The males in their late 30s or early 30s presenting with this kind of presentation. Again, sarcoidosis is also similar to TB also in its pathology, because they're both granulomatous disease. So they both form granulomas. So you have to be extra sharp to identify a potential case of sarcoidosis. Metastatic cancers as well, like renal cell carcinoma, thyroid cancer. In women, you find choriocarcinomas. Again, these can present multiple mets to the lungs, and be a confusing picture, and you may think you are dealing with TB. Next cases. So another common X-ray that you come across routinely on your daily work is patients who present with the hilar adenopathy or mediastinal lymphadenopathy. So if you recall, why I put the first X-ray on the case is because of this same typical presentation. So because the people who treated that case for TB considered that what they thought was on the X-ray, what they thought was hilar adenopathy, and they decided to treat that patient for TB. But I want you to guys also have an independent thought on the X-ray, and most of you have submitted your responses based on the scenario that I gave. So perihilar lymphadenopathy is a very common X-ray finding. Things to consider when you see such an X-ray, other than outside TB, lymphoma, metastatic disease, sarcoidosis itself should be considered, as well as the fungal infections and other viral infections. Like ABV, CMV, this you find, especially in the context of HIV, essentially because those are lymph nodes, essentially it's consider anything that can result into lymphadenopathy as a potential diagnosis for such a patient. Next, another common presentation is pleural effusion, where it's probably the most common diagnosis, extrapulmonary TB diagnosis, based on the data that we had looked at the National TB and AIDS program. This seems to be the majority. Essentially, over 80% of patients seem to have had pleural effusions as the basis for TB diagnosis. So, but differentials for pleural effusions include pneumonic effusions, heart failure, empyema, malignance as well. Pulmonary embolism. Pulmonary embolism is actually very interesting. Pleural effusion in pulmonary embolism is actually very interesting because potentially this is a patient who has who has an emergency, and then we don't recognize that someone who has pulmonary effusion could be due to actual pulmonary embolism, and they can die in a very few days, actually in a matter of days, if you don't identify. So those of you who may wish to know that we actually have currently such a patient on the ward in UTH, where he presented very advanced HIV disease, presented with the respiratory symptoms, and everything was pointing towards TB. So what we did is we started the patient on TB. I mean, like, he's wasted. Everything was pointing towards TB. It was very difficult, but we still went ahead and did a high resolution CT scan, and then the CT scan radiologist decided to do angio as well, because the CT scan looked very suspicious, and we were able to confirm that indeed the man had pulmonary embolism as well. So now the question now became whether the effusion was due to pulmonary embolism, or the question was due to the effusion was due to TB, as the history suggested. So we decided to treat the patient for both. So the patient has been on the ward for close to 2 weeks now. So we are confident that he may actually pull through. But without us identifying the pulmonary embolism quickly, he would have been a mortality by now, because pulmonary embolism has a very, very, very high mortality. If it's unrecognized, it's almost 100% mortality if it's a massive pulmonary embolism. The other presentation that you need to be aware of is connective tissue diseases. These are very common in women. Okay, and if you paid attention, the both cases that I've put were females. So there's a purpose. I deliberately put that on purpose, so that to see if people would think of connective tissue diseases. So connective tissue diseases are autoimmune diseases. Among the commonest one of the type that we see common is the systemic lupus erythematosus, or SLE. So most patients who have SLE can have pleural effusions. Even patients who have rheumatoid arthritis, again, which is a very common rheumatological disease, can also present with the effusions. So all these differentials should make you appreciate that, or question whether what you are dealing with, what you are looking at, you are looking at TB or any of these other differential diagnosis. So every time you see a woman, always think, is it potentially someone who has an autoimmune disease, an autoimmune process going on, SLE, rheumatoid disease, or scleroderma, any of those connective tissue diseases. Next. Another finding on X-rays is fibrosis and volume loss. So if you pay attention to some X-rays, you can appreciate that the X-ray, a lot of changes. Usually, they seem to occupy the whole lung for the patient. Patient is usually comes out of proportion in the respiratory distress. When you look at X-ray, you can see a lot of fibrotic changes. Sometimes even cavities can be present, and these are the things that usually some patients some clinicians may decide to treat as TB. Most of these patients would have been treated for TB on multiple multiple times, 3-4 times, but the X-ray does not change very much. And the radiologist who experience clinician will tell you that it is actually there's no lung this side, there's lung collapse this side, so there's a volume loss. So most of these patients may also this presentation may also be because of untreated healed lung or healed fungal infections or radiation. Someone who has been exposed to or treatment for cancer and has developed radiation. There are also other drugs that can cause lung fibrosis as well that you may want to know that there are some lung like methotrexate. Some of these diseases are lung drugs that we use to treat patients who have autoimmune diseases like methotrexate can also cause lung fibrosis. Bronchiectasis is also a clinical that can present this way. This is usually post-infectious, or in some instances, cystic fibrosis in patients who have cystic fibrosis, especially if the respiratory symptoms started when the patient was on the younger age. I tell you, this problem has been going on from pediatric age, has been treated for TB in the pediatric age, but not much changes. It could be just an issue of cystic fibrosis. So by post-infectious, it also includes TB in this case. So it could also be because of post-TB lung disease, in other words. So it also could be due to idiopathic pulmonary fibrosis. For example, in a patient that we received this week, all the way from Solwezi, has some of these features, and even Solwezi was able to accurately identify that the patient potential as the usual interstitial pneumonia, which is another example of abnormal X-ray that can present like this. So I've gone through. I know I'm speaking fast. Sometimes maybe you didn't read about these diseases before, or maybe you remember reading about them in while we were at school, or you've never seen such a case before. So you will forgive me because I'm just going through the trying to make you appreciate the range of diseases that can present as TB on chest X-ray, so that in the future, as you are assessing these patients, you have to take that into mind. So one of the things that I've not shown on the slides is that most of these decisions, or most of these differentials are tied towards the way you assess the patient at presentation. That history you take from the patient is very important. Most of us are very impatient when taking history from patients, or we don't ask the key questions that can help us arrive at a particular differential diagnosis. Okay, for the sake of TB, if you are thinking the patient has TB, for example, you have to ask if they've been treated for TB before, how many times, if any of those episodes was ever confirmed on sputum, was it ever bacteriologically confirmed? So this kind of thought process helps you to identify or to come up with a potential differential diagnosis. Those of you, like I said, those of you on culpability, if you assess the patient, whether the patient is a minor, has worked as a minor, history of smoking. For women, constitutional symptoms also are very common in autoimmune diseases. So they will come to you presenting with weight loss, fevers, sweating, and you may actually get confused to see whether you are dealing with TB or not. This is why the program emphasizes that whenever I suspect TB, you do your usual, you follow the usual algorithm, sputum gene expert. Those who qualify for urine lab, they qualify. But when the results come back negative, you may have to pause even for a minute and consider that is something else going on in these patients. It's not automatic that because the chest X abnormal, it's not automatic that the patient has TB. You have to discuss. And this is where I always encourage people to learn how to interact with other colleagues, whether within the same facility or within the same district or province, or you can copy other people that may be in other provinces and discuss such a case, so that you are sure as well, so that you are sure of what you are doing with the patient. In the past, we've previously shared a clinical pathway algorithm, and I hope most of you remember it, If you don't remember it, reach out to your provincial TB programs. They should have at least a soft copy of that algorithm that we went to see and assist people how to investigate a patient if they think the patient has TB, but he cannot confirm it bacteriologically. And this also helps you to consider all these differential diagnoses that I've mentioned. So you already the radiological diagnosis of TB is not as simple as we always thought, that an abnormal X-ray is automatic. So for those of you who maybe at your facility have other modalities, imaging modalities, you can go to the next slide. Other imaging modalities are variable. Other imaging modalities are variable. Ultrasound is very common, but ultrasound for me requires people who are very experienced to see so that they know what they are looking for. So sometimes you can take a walk at it as a clinician and have a chat with a person who's doing ultrasound. For example, if you're interested in ascites and you think this ascites is TB, you can take a walk and tell them, I think my patient has TB. I want you to pay attention to the type of ascites the patient has, so that you can be confident that this ascites is because of TB. So usually they'll describe things on ultrasound like fibrin strands, or they will mention things like septations. So to be a complex ascitic fluid, septations will be some description. But unfortunately, most of the ultrasound, if there are any people who are working in radiology, for the purpose of clinical, from the clinicians usually want more information from your description. Rather than just saying ascites is present, it's better to say whether you are dealing with what kind of ascites you are dealing with. That helps the clinician. Also, ultrasound, even here in Zambia, is being evaluated for the use in the diagnosis of pulmonary TB. So this will be an addition to the chest X-ray that we are using currently. So at one point we'll be using ultrasound, point of care ultrasound, which you can just carry in your pocket and quickly look through the patient's lungs and see if this is a potentially TB or not. So you can see the uses of ultrasound actually wide. I think even in PIDS, they use it for the brain. For some countries are using the pediatrics age group. They're using it for skull ultrasound. Probably at one point we'll be using the same skull ultrasound to assess for TB meningitis or something like that. So ultrasound is a very versatile platform that we can use. Another form of ultrasound is echo. Again, it is becoming widely available countrywide. I think almost all provinces have access to echo now. So echo is very important when you're evaluating patients with cardiovascular disease, but also in patients who you are suspecting may have TB. So the thing with the patients who have TB pericarditis may initially present to you as heart failure, and some of them are initially treated for heart failure, so they are put on diuretics, and then they are being treated with the beta blockers and hypertensive, and they have got a diagnosis of heart failure, when in actual fact, they've got TB pericarditis. So again, this is also dependent on the one who's doing an ultrasound. The one who's doing the echo should be able to identify key features that would suggest a TB, like the fibrin strands that I was mentioning. So these are some of the descriptive things that you should be asking for when the echo comes. So if you are not satisfied with the echo report, take a walk to the one who's done an ultrasound and tell them, I was thinking my patient has TB of the TB pericarditis. Is it what you think is? Because the echo does not give me more information, so I can't tell whether this was just an infusion due to heart failure, or was it an infusion due to TB? Again, if you have access to CT scan, again, this is CT scan access is expanding slow but surely. One of these days, almost every provinces will have access to CT scan. So this CT scan is another tool that we can leverage outside the chest X-ray, especially where the chest X-ray is not clear, or you've disputed among yourselves where you are not sure. Then you can say, okay, can we do a CT scan to see if it can give us more information on top of the X-ray. So usually the CT scan gives more information. On X-ray, it's more sensitive to pick more cases of TB or pulmonary TB if it is missed. So CT scan also can be used to assess for TB meningitis. There are specific features that they will look for when they're assessing for TB meningitis, like tuberculosis or they said a particular pattern in terms of the way the CSF fluid is viewed. So usually the CT scan report would say we ask you to maybe to do CSF studies to rule out meningitis, and one of those meningitis you are ruling out is actually TBM. Also, it's very good at diagnosing abdominal TB. Here, because of my personal experience, I would like to bring to your attention some of the cases that I've seen of abdominal, on X-ray of abdominal TB, are patients who have specific masses around the kidneys. So the report will report to you that there's a mass seen around the kidney. So I've personally treated about 3 cases so far successfully and lost 2 cases. The reason why I lost those 2 cases, the reason why I'm mentioning this, because the two cases that I lost were had to undergo a nephrectomy, meaning that they had to remove the whole kidney because the working diagnosis at this point was the renal cell carcinoma. But when the biopsy came back, it just said it was actually TB granulomas. You can imagine a patient has lost the kidney, they've gone into kidney failure, and the biopsy comes back and tells you this was actually TB. So when you see masses in the abdomen, in other words, when you see masses in the abdomen, even in the pelvis as well. If you look at some paper, I think Professor Vuarik has done a paper. If you search on one of his publications, he has described a case series of pelvic TB, where patients were either given a diagnosis of ovarian cyst, or they were given a diagnosis of ovarian cancer, or they were given a chronic PID, but they all turned out to be TB cases. So you can already appreciate that the TB it presents in a very vast way, and the diagnosis using imaging is not as there's still a lot of challenges that you are going to face when you are diagnosing TB using these imaging modalities because of factors like sensitivity and specificity. So specificity for this is usually on the lower side. Okay, sensitivity is usually on the higher side. But WHO, for example, for WHO to recommend a imaging test as a tool for TB, looks at specificity and sensitivity and specificity of above 70%. That's when they will regard this as a very good tool. But some of these imaging techniques do not meet that sensitivity or that specificity that WHO requires. That's why, for example, the chest X-ray is being pushed mostly as a screening tool rather than a diagnostic tool. But of course, in our programming, we've used chest X-ray a lot to diagnose TB. Now, I'm sure you appreciate now the limitation the chest X-ray has in the diagnosing to say this is TB because of this wide range of TB differential diagnosis for TB. Next slide. Okay, back to the poll. Over to you, Nate.
Great, thank you so much. So we're just going to go through these 2 poll questions, the same cases. We have a 39-year-old female with a 1-year history of chest pain and weight loss, HIV negative, has no TB contacts, past medical history was significant for COVID-19. Does this patient have any TB, or is there any other differential you would think of at this point? So the options are sarcoid, lymphoma, TB, or was this a normal X-ray? So 39-year-old female with that 1-year history of chest pain and weight loss. She's HIV negative, no history of TB contact. Past medical history was significant for COVID-19. Based on that X-ray, did this patient have TB or any other differential diagnosis? So A, sarcoid, B, is it lymphoma, C, TB, or D, is this a normal X-ray? Okay. So let's all make sure we participate. I should be ending the poll question soon. Let's all participate. All right, so Dr. Mputu, I am sharing with you the results. We have 33%, which is majority, that went for this is a normal X-ray. 31% that opted for option C, being could be TB. 22% that could be sarcoidosis, and 16% opted for lymphoma. Your comments around this?
Maybe some people can volunteer why they would that be okay? Because I'm sure I know the poll is usually anonymous because people don't want to say. Maybe someone who's brave can defend the answer.
Great. So yeah, I'm gonna stop sharing so that this can show. Yeah. So network. Would any of you like to unmute and maybe give your thoughts on this case and differential diagnosis relating to this?
So when you are discussing, you have to take into consideration the picture that I've provided, the clinical symptoms and the history that I've given.
Yep. So the 39-year-old female with a 1-year history of chest pains and weight loss is HIV negative, has no TB contact, has a past medical history significant for COVID-19. Could this be TB, or could we be thinking about anything else apart from TB from this scenario and the chest X-ray provided? Anybody would like to take that up? Remember, there's no wrong answers. We're all here to learn at the end of the day. Okay. You can just raise your hand or unmute yourselves and then go ahead. All right. Great. We've got Loveday Muila. Please go ahead, unmute yourself. Thank you so much.
Thank you. Good afternoon, Dr. Mputu and everyone. I'll go for lymphoma. I don't know if it's my eyes. Around the mediastinum seems to have enlarged lymph nodes. They're in the middle. So I thought it is lymphoma, some consolidation. But my eyes could be cheating me. I put on glasses. I submit.
All right, great. Thank you so much for your submission. So we've got lymphoma. Anybody else would like to give it a shot before we ask to input? Great. Please go ahead, Kelvin Kunda. Thank you so much.
Yeah, good afternoon, Doc. From the presentation and from the X-ray, I would go for D.
Okay.
Because I see the X-ray fields are clear. I was trying to see some cavitation, consolidation. It looks like there's no clear evidence of TB here. I just want to try. You can guide.
Excellent. Thank you so much. This is great. So we've got considerations for lymphoma or a normal X-ray. Anyone else, or Dr. Mputu, would you like to weigh in now?
Okay, for the sake of the next case, so let's see. Majority of you actually are right that this is just essentially a normal X-ray. So I've seen that most people don't take the sex of the X-ray. I'm sure maybe Ten is on the call. Maybe can add to my voice because him is the radiologist. But from the clinical aspect of myself, what I've noticed is when you're interpreting X-ray, you don't consider whether the X-ray is for a man or a woman. So sometimes the breast tissue itself can confuse you. So when you can look at the breast tissue, you think this is abnormality when it's actually it's breast tissue. This X-ray, when we discussed it as a team, we concluded this was a normal X-ray, and the radiologist also agreed that this is essentially a normal X-ray. What people are thinking is abnormal or lymph nodes, actually not lymph nodes. This is just prominent, some vascular matting or some. So it's not lymphadenopathy. So this is essentially a normal X-ray. Sarcoidosis is a good attempt because of the age group, and also because this is usually in females, sarcoidosis starts peaking after the age of 40. So when after around the age of 40, you may start seeing more of the female presenting with the sarcoid than the younger age group. In males, I think it presents a bit lower area, like 25 to 30 age, but with women it peaks at about that age group. So it's a good attempt. I know those of you who thought this was TB again. Of course, you can argue that you can't use this X-ray to say this is not TB because it's normal X-ray, like I said. But this patient's sputum was actually negative. The culture was also negative. Okay, so the history of a chest pain for this long and weight loss for this long would probably make most of you really consider treating this patient for TB, for which she was actually treated for TB at the center where she was attending based on these symptoms. Okay. But there are many things that can cause chest pains. There are many things that can cause patients to lose weight. Among them, like I said, in females, you have to consider autoimmune diseases. Also, whenever you are discussing, when a patient presents with pain, always verify to understand exactly what they mean. Okay, people in Africa, from my observations, we are very bad at describing what we see, what we feel. We are not good at description. Probably this is why you never see a wanted person with a cartoon for a wanted person in the police. Zambia police, you will never see them showing you on TV that this is a wanted person, and because it's a cartoon. Because most of us cannot describe what we are seeing. We can see a thief, but you can't say he's male, he was this, but it's very difficult for Africans for some reason. So even when they have got these symptoms, they really don't know how to express their symptoms for. So you have to take time with them, what they mean by chest pain. Okay, and then try to characterize this chest pain further so that you get a clear picture of things. Sometimes the chest pain is not there consistently, it is related to activity. For example, when they carry heavy weight, which would mean maybe the issues to do with the rib cage itself, not necessarily the lungs. So always get this clear history so that you get guidance some more. Next case.
All right, great. Thank you so much. So we've got a comment from Obert Simukoko. Thanks for that. So comparing both sides, this looks like it's normal. Yes, that is true. So our next case, I'm just going to kindly have a look at that X-ray. So female, 39, with 10 days history of a cough, 7 days of sputum production, she had fevers, and 4 days of chest pain. And she had one TB episode 3 years prior. And she's HIV positive since 2010. So what could be your differential diagnosis? Is this TB? Is this something else? So option A being TB, B being lung cancer, C, is this post-TB lung disease? D, is this heart failure? So a 39-year-old female with 10 days history of a cough, has had sputum production for 7 days and 4 days of chest pains with fevers. She had one TB episode 3 years ago and has been HIV positive since 2010. Could this be TB or could this be something else? So let's all ensure we participate. This is our last poll for the day. Okay, so we're getting some great participation. Please do continue participating. Okay, I'm gonna end the poll question now. So Dr. Mputu, sharing with you, we've got 68% that opted for TB, and then 17% for post-TB lung disease, 7% for lung cancer, and 9% for heart failure.
Okay. Thanks. Maybe one or two people can tell us their thought process, why they thought this was maybe heart failure.
Great. So network, would you like to unmute again? For those who think it's TB, for those who think it's heart failure, or those who think it's TB lung disease.
Good afternoon. I went with post-TB lung disease because I saw there's extensive fibrosis in the lungs, and there's also some loss of lung volume on the X-ray, and also seems like there could be some hyperinflation of the lungs. That's why I went with post-TB lung disease. I submit.
Perfect. Thank you, Dr. Simukonda. Any other thoughts? There's Chacha Amonga, you've unmuted. Would you like to weigh in?
Okay.
Okay. Obert Simukoko. Okay. Yes, Kelvin Kunda, you may go ahead.
Yes, Doc, I just want to concur with the previous network, the findings on the X-ray, but also to add the findings plus the history that we've been given, like the history of HIV and also past TB episode. Those are just additions to what the previous network contributed. Thank you.
Perfect. Thank you so much. Any other thoughts? Any other thoughts? So we've got.
I would like to hear from someone who said this is TB. I want to hear their argument.
Great. So anybody who thinks this is TB, please go ahead.
It's TB because there's some cavitations and opacities on the lower right bone, just near the point from the right side. And then also there's some deviation of the trachea. And also on the left lower lung, not that clear.
Great, thank you so much. Thanks, Jennifer. So Jennifer says there's cavitations and the trachea is also deviated. And that's why she thinks it may be TB instead. Yep. Dr. Mputu, over to you.
All right, thanks. So thanks for the attempt. The distribution this time is a bit more leaning towards the TB. So there's a few of you, about 9% of you have thought heart failure. So again, this is a good opportunity to explain the importance of history in a patient who presents to you. That should help you arrive at a particular diagnosis. So the symptoms here do not suggest that the patient has heart failure. The symptoms, first of all, are short, would be typical of a case of a pneumonia in a patient who had the previous episode of TB. So the lung actually shows you, of course, this is PTLD, based on that previous history and all the fibrotic changes that you can see on the what, as the Dr. Simkonda indicated. The sputum for this patient was negative on GeneXpert as well as culture. It was negative. So we did effort. There was an effort to exclude active TB in this patient based on the short duration of typical presentation of a pneumonia. It's a cough, then it becomes productive. Then what usually triggers patients to come to the hospital is when they develop chest pain. So this is a classic presentation of a community-acquired pneumonia in a patient who was post-TB lung disease. So it doesn't require you to have several TB episodes. Just one TB episode is enough for a patient to develop post-TB lung disease. So one episode of TB should never exclude PTLD. One is just enough. So unfortunately, some patients have to have multiple episodes of TB, or they will be treated for several episodes of the same X-ray, thinking that this is TB when it's actually not TB. Lung cancer is a bit more on the remote in this patient, less likely for this patient to come with to have lung cancer. Usually, the risk factors would have been made very obvious in the history that was given to you. For example, would have indicated things that she's a smoker for the past so many years. That would give you a hint that someone is thinking about lung cancer. So this patient was treated for pneumonia and was being treated for TB lung disease. So we can already see, like I'm saying, that when you're assessing these patients, you have to first put the clinical picture in context, analyze the imaging and understand the imaging, what the imaging is telling you in relation to the history that you've taken, and consider a variety of differential diagnoses. Of course, there are certain supportive tests that I've not mentioned that could help you, especially if you're suspecting an infectious process. One of the supportive tests that you need to get used to asking for is whenever you think of an infectious process, is using CRP. If a patient who had such an X-ray and came coughing or has got hemoptysis and then CRP is normal, would say effectively tell you at a very high likelihood that this patient has TB, because CRP is a very good screening tool as well. If you pay attention to the guidelines, I think CRP is mentioned on a number of places in terms of TB screening. So some of these things are available right now in the country, and whenever you're evaluating patients, you have to consider further testing before you make a decision of treating patients. Again, it's very rare for you to have an emergency for treatment of TB. I know that the program has pushed for people to be put on TB treatment as soon as possible, but that also should be weighed with the balance of over treating a patient who does not have TB. There's a data that is being looked at. Probably in the next few months, we'll present this data to show the different kind of X-rays and what had happened to these patients, whether indeed they had TB or not. So this data will be shared with you, hopefully on this same platform. Please remember this discussion, and so that you appreciate that the majority of X-rays that you see don't necessarily mean patients have TB. They also mean that it could be something else that is potentially going on with this patient. Importantly, is also while I'm emphasizing that we should always emphasize about differential diagnosis, I'm also emphasizing that it's what you are doing right now to think about TB in such patients is actually the correct thing to do. So that's the first thing you should think of. When you see such an X-ray, you should ask the first question, is this TB? It means that you start working from there. So once you ask yourself, is this TB or not TB, your evaluation of the patient will work towards excluding TB or confirming TB. Once you exclude TB and you are confident that you've excluded TB, that's when you consider these other differential diagnoses. I am not encouraging you to just look at TB and decide this is not TB. Okay? What I'm encouraging you to do is when a patient comes to you, think TB. Once you think TB, evaluate. If you don't have any convincing evidence that this is TB, then consider other differential diagnosis. I hope my take-home message is loud and clear. Over to you, Nai.
Great. Thank you so much, Dr. Mputu. This was surely something great to discuss, and it was good seeing. It's good to see that we have so many other differentials beyond TB and that we should think about. So many mimics of TB. So at this point of time, I'm gonna open up to the network. Would you like to ask any questions? Do you have any contributions for our presenter? Okay, Grace. So we've got a hand raised. Grace, kindly unmute yourself and go ahead.
Thank you so much. Mine is a question. I would want to find out how often are we supposed to subject the patient to radiological examination, given that we're given a memo to say we need to be using chest X-ray for TB screening. So let's say there's a presumptive TB case and we subject them to a chest X-ray. Then based on the results, if it's suggestive of TB, we're supposed to collect a sample for gene expert. So considering that time and again, an individual would present with those signs and symptoms. So how often are we supposed to subject them to chest X-ray? Thank you.
All right, great. Thanks for that, Grace. Dr. Mputu, would you like to take that, or anybody in the panel of experts?
I would like to share my thoughts.
Sure.
So she correctly puts it, to an extent, she's already answered that one question by mentioning the fact that there's a memo that says use chest X-ray to screen for TB. So usually when you screen for TB using the chest X-ray, the one that is most likely going to get you some more results is the one that's usually very suggestive of TB. So an abnormal one with some infiltrates or something like that. That's why we're saying that when you use an X-ray for screening, the sensitivity for screening, meaning that an X-ray can catch up to the sensitivity about 68 to 70%, meaning that out of 10 patients who have TB, when you screen them with a chest X-ray, the chest X-ray will pick up abnormalities in about 7 of those out of 10, approximately. So once you have that X-ray, the next thing to do is just normally to do the rest of the workup, sputum, cultures, and all those things. At this point, there will not be any need for you to resubject a patient to the chest X-ray. Okay, because you already have it, so you don't need to repeat after you've done the screening, because the screening already will tell you. So what you need to do now here again is to go back and look at that abnormal X-ray that made you look for sputum and start questioning yourself whether that abnormality we saw was through TB or it's something else going on. In some instances, if the picture is still not clear, this is at the point where you want to do other advanced imaging like CT scan of the chest. Of course, the concern is always there about exposure to radioactive issues. You want to minimize exposure of a patient to radio X-rays or other form of radiation. You want to minimize. So this is one of the reasons why we have not encouraged the use of X as part of monitoring tools. That the patient has a chest X-ray at beginning, at 2 weeks, then and at the end of the treatment. So we discourage this because of the same thing, that we want to minimize the exposure of these radioactive X-rays to patients, especially that the guidance is already there telling you that use this for screening. If it's abnormal, then you use this for further testing. When the chest X is normal, very unlikely the patient will have TB at that particular point, especially if they're already at a facility. Perhaps maybe for community screening, people would come. Sometimes people just want to have an X-ray, but there's no particular symptoms. Then boom, you find an abnormality that would suggest what you call subclinical TB. So again, even if you find subclinical TB, it does not mean that do another X-ray. It will not add extra value. The repeating of an X-ray after you do a screening test X-ray does not add extra value. It will not change the information for you. It will, you can ask is X-ray today. After 1 week, you do another X-ray. It will just give you the same information. Okay. You may have dealt with the people from the old school, like in the 80s, like clinicians from the 80s, had the habit of doing an X-ray today. They treat someone antibiotics. Then after antibiotics, they want to do an X-ray to see if it has resolved. So this used to be the habit. But now we are more conscious. We are a more conscious workforce these days because we put patient safety at the center of everything. Is the patient, why am I exposing this patient several times? It's not indicated. So there's no need for you to keep asking patient to redo X-rays when you've already done an X-ray for the screening. The rest of the workup has to be the usual sputum, culture, and all, and stool gene expert, and all these other modalities.
Thank you, Dr. Mputu. Any other questions? We've got a comment from Brian Sitenge. Thank you. So Brian has a comment saying gene expert is still a golden investigation for presumptive positive cases. Thanks, Brian, for that. Any questions, any other questions or contributions from the network? I see we're joined by Dr. Chitanika Chalomba as well. Thank you for joining us. He's our expert on today's panel. Would you like to say something, Dr. Chitanika? Or if anybody from the network would like to contribute or ask a question, please go ahead.
Hi, Dr. Naik. Just confirm if I'm audible.
Hi, Dr. Chineka. Yes, you are audible. Thank you.
All right. No, I've been following the presentation. I think it's a brilliant presentation from Dr. Mputu. Again, just touching on some very, very pertinent points to say that I think that the biggest thing is which I can mention is that as he stated to say, when you are suspecting TB, obviously because it's quite common in our setting, it's okay to think about TB, but also it's important to keep it at the back of your mind that that there are other things that can cause that. I will let you know, Dr. Naik, and for the benefit of the people on the call, that one of the most frequent pitfalls that we encounter, even when we're on our travels, when we're on our travels, is that you'll find that you have this place where you have someone who has been put on TB treatment maybe 3 times, 4 times, and when you ask why this has happened, they'll say, no, we put someone on TB treatment, and then when we did the repeat X-ray, we found that there was no change. So I think we also need to raise a lot of awareness, I think, as Dr. Mputu has done, on post-TB lung disease, that for some people, even after they do get treated for TB, you do get some residual damage. The same way you get scarring of the skin, you can get scarring of the lungs, and that actually can show up as opacities on the chest. So just to be a bit cautious in those lines. Those would be my comments for now, Chair. I submit. Thank you.
Thank you for those remarks, Dr. Stanika. I really appreciate you. So we do have a comment from Grant Banda, who says repeat X-ray after treatment can also make a clinician mistake scars for lesions, which is great, which is quite important as well. Yeah. So if there's fibrosis on X-ray, you can be confused for a repeat TB episode. People continue treating for TB, but this instead would end up being something like post-TB lung disease. So that's an important point. Thank you for that. Any other contributions or questions before we close? Network?
Hello?
Hello, Humphrey Chanda. Please go ahead.
Yeah, this is Dr. Chanda from Mandevu.
Great.
So just there's something that I've encountered that I've not been comfortable with. There's this ratio that you say, I don't know, it's part of the programming, where, and correct me if I'm wrong, where they say 60% of TB cases have to be bacteriologically and 40% radiology. I don't know, is that correct before I proceed? Hello, Chair.
Hi, Dr. Chanda. Thanks. So you're saying that 60% of TB cases have to be confirmed?
Yeah, there's this, I don't know.
Periodically.
Yes, and only 40% have to be radiologically confirmed.
Okay. Let me ask our experts to weigh in on that. Dr. Mputu, Dr. Stalu.
I think he has another question. Maybe you can just say the second part of the question. Sounds like he's got a second part of the question.
Okay, yeah.
Sorry,
So
maybe-
what I'm asking
maybe-
is,
maybe through
I
the-
get concerned because sometimes, especially in HIV positive clients, it's from the studies and from the literature that we have, it's a bit difficult to get bacteriologically confirmed TB. And when we have these meetings that we have weekly, and you have a lot of TB, maybe 100%, 80% diagnosis based on X-ray, some people get uncomfortable, or that you have a lot of X-ray confirmed TB as opposed to bacteriology confirmed. So I don't know if this is the guidance or the guidelines concerning this. That's why I was asking this question. Thank you.
Good
Oh, great.
afternoon, through the chair. Yeah,
Please.
maybe through the chair. This is Ruth from Eastern Province. So the guidance is that actually not even 60%, 70% are supposed to be bacteriologically confirmed. Then 30% clinically diagnosed. So I think that's where he was trying to refer. Yes, that's what they say. That's the guidance we are given actually.
Thank you, Ruth. Thank you, Ruth. Yes, Dr. Mputu, you may go ahead.
Yeah, actually, this is the target that is being recommended that shows a very well functioning TB program. WHO actually wants, if you can get 100% confirmation, it would be a very nice thing, but we know that's not practical. So this is why even the program's target is to reach 70% of target, where patients should be confirmed bacteriologically. One of the ways that this target has been discussed internationally to achieve is to look at improved diagnostic tools. We have a gene expert, we have culture, we now even have urine lab. In the next few months, probably to extend. There are even some studies are actually going on right now in the country, even using in oral swabs. So people are looking for how to catch these TB cases that confirm them bacteriologically. It does not mean that you are not allowed to make a diagnosis of TB radiologically, because clinical diagnosis of TB still plays an important role, and in fact, WHO acknowledges this. A lot of experts worldwide are writing papers about this, that this cannot be overlooked, especially in our country where the burden is very high. In other countries like the USA, they probably won't think much about an abnormal X-ray as being TB, because it's not very common. Here, we have this challenge of deciding whether someone has TB or not because of the high burden. You say you're coming from Mandevu, Chipata level 1, if this is where you're working through, is now almost catching up with Kanyama in terms of notifications. Kanyama and Chawama were the top TB centers in Lusaka. And now, if you look at the numbers of Chipata, are going towards the Kanyama levels now. So probably we're going to see a shift of TB surrounding your locality there. So you have to be aware that most of those patients, you have to try by all means to attempt to confirm them bacteriologically. One of the reasons why we push for this target is to discourage people, to encourage people to do the actual testing that they need to be done. In the past, we are coming from places where a lot of our patients were not being subjected to sputum testing, but they were being diagnosed just like that. It is just one X-ray, TB testing, and then you find that we are missing cases of drug-resistant TB. We are missing cases of other forms of TB as a result because someone has just relied on an X-ray. So this exercise of discussing TB in the context of clinical TB actually started recently in the country. If I recall, just during the COVID period, that's when we started paying attention towards clinical diagnosis TB because the data kept showing that the testing was still below par. So now we are seeing a jump in the testing of sputum. So this is a good thing. That's sputum. People are being tested for sputum, but your effort should always be there to ensure that even as you make a decision that this is radiological TB, at least you should be comfortable saying that at least I did what I need to do. I tested this patient using this and this and this as a specimen. Therefore, I could not prove that this patient has bacteriological TB, but my clinical judgment has told me this patient has TB. So we don't want those who are clinical judged to have TB to be the majority. We want them to be the minority because that is what is expected. That's what data says. I know the challenge most of you have is, but every time everyone I'm testing is not the negative. Is a negative. The answer there is simple. It may mean that the people you are sending for testing are not actually true presumptives. When you identify a true presumptive, there are a very high chance that you're going to find the bacteriological confirmed TB. So always look for the true presumptives. Then you are going to increase your yield of bacteriological confirmed TB. This has been done in a number of centers countrywide. Some of you are at centers where you yourselves can see that the number of bacteriological confirmed TB is increasing. And usually you get excited about it. Look, we've got more bacteriological confirmed TB now. But if you look at your data from before, most of your patients were clinically diagnosed. That means that there's something that you are doing that has changed that particular practice. Chair, I'm seated with Dr. Shai. Wants to say one or two things.
Thank you, Dr. Chitalo. You may please go ahead.
Hi, Dr. Neil. Thank you so much. Waste of time. Interesting discussion. I think that probably going through the comments, I think most of us who attest that it's very difficult to get a diagnosis of TB, especially in someone with advanced HIV disease. I think there are several reasons for that. I mean, some of them are, I'm not sure if you're getting me. Some of them are patient-related factors. Just the mere lack of immunity means that you not really concentrate that TB in the lungs. So it might then extend into other places other than the lungs. And therefore, even an X-ray might actually look normal in most of these patients. So be cautious when we see these patients. But also, I think that there was a colleague who mentioned that we need to test the presumptives. I think this was Brian Stenge, who said we need to test the presumptives with an expert. Now, in patients with advanced HIV disease, really, the symptom screen for WHO might miss some presumptives. And I think most of us have seen that the patient, when you're screening for the first time, they tell you they don't have symptoms. You start them on ART. 2 weeks later, they come back with very worse symptoms, bad X-ray and all that. And this is because the symptoms can be missed, and that's why it would be good that in these patients, then you also want to add an X-ray, and you might find that maybe you get a true presumptive. When we look at these patients, if you get a positive result from sputum, I always tell people you're lucky. You are more likely to get a negative result because you have very little TB in the lungs. So something just to remind ourselves that it's not a very straightforward road when we're thinking about pulmonary diseases or TB in the lungs in patients with advanced HIV disease. We need to bear in mind also that the X-ray will look normal, and as Dr. Mputu has said also, that you can get things that will appear like TB on an X-ray in someone with advanced HIV disease. And sometimes you can move from the hilar, you can go into the parenchyma, you can go into the pleural space, and all these features might look like TB. So I always say when you look at an X-ray, it's like a shadow. It doesn't really tell you if what you are seeing is a human being or you are seeing a male or female human being when you look at a shadow. And sometimes you can tell. So when we get an X-ray, please, we want to confirm what we are suspecting on an X-ray, because sometimes you could be treating for TB, and based on what you see as hilar lymphadenopathies, and because it's a commonest thing. But I think we've also seen patients with fungal infections presenting with hilar lymphadenopathies, and you find you hammered this patient with ATT for a long time. They finish the ATT, but the lymph nodes or the hilar lymphadenopathies are still there. The effusion is not coming down. So even when you suspect, you start your treatment, you need to think about, could this be a fungal infection based on the CD4, okay, based on the environmental exposure, and based on the way the patient has presented, and how is the patient responding to this treatment. We've seen some patients being treated for TB, when in actual sense, when you look at the X-ray, they might have fibrotic changes, and when you do your workup, you find this patient just has a non-tuberculous mycobacterium. You realize that the treatment for non-tuberculous mycobacterium has some component of the TB drugs. So the patient will improve slightly, and then they will up to a certain point because you don't have full therapy. So it's very important in such patients, you want to get the expert done on the patient. And the experts, remember, its sensitivity or ability to pick TB might be a bit lower in people with very advanced. And then you want to wake up for a fungal, depending on your setting, also depending on what you find. We've seen patients who have been treated for TB, all they had was aspergillosis, and as invasive pulmonary aspergillosis. And some of them they've had MAC, which will present similarly to Mycobacterium tuberculosis. So if you get a good X-ray, that doesn't mean there's no disease. It means that there might just be no pathology going on there, but the disease might be there. So you still need to look for TB. And you need to look for TB in various tissues, in various samples besides the sputum, and that's where things like stool come in for you to explore, tissue biopsies, and some patients have done bone marrows. So that's very important as we explore these patients. I think the X-ray really helps us to find true presumptives and not to miss some patients. But again, it really is very non-specific, and some pathology will remain there even after the patient has finished treatment. But I think you want to confirm the diagnosis and know which type of TB you're dealing with. Is it drug susceptible? Is drug resistant? Is it a fungal? Are you dealing with a malignancy? Is it an autoimmune process that you're dealing with? And that will help you to manage your patients and review the response of the patients. Thanks.
So much, Dr. Chitalo, for those clinical pearls, very, very important in practice. So we've got 4 more minutes remaining till our time is up. We've got a hand up from Dr. Humphrey Chanda. We'll take one of those as probably our last question or contribution. Dr. Humphrey Chanda, please go ahead.
Yeah, thank you very much, and Dr. Chanda. Thank you very much for that explanation. So, I've got one concern. I know that this echo session is trying to raise the awareness on TB diagnosis using X-ray, but the majority of the people that the cases we get are from OPD, and unfortunately, they do not log in these meetings. So my concern is, what can we do more to involve our colleagues who work in OPD? Because often we find clients who've been coming for a cough for over a year, for over 2 years, and are being given amoxicillin and other antibiotics, and there's low index of suspicion for TB. And I'll say this unapologetically, they lack knowledge in terms of reading X-rays. So I don't know, is there something that the ministry or that we are doing, or the TB program, to help other colleagues? I'm sure the people that are logged in this meeting are people that are, in the CDC or PEPFAR supported programs, and the majority of people who work in OPD are on the other side, and these miss a lot of clients in terms of TB. Thank you.
All right, great. Thank you, Dr. Chanda, for your contribution. Dr. Mputu?
Yeah. So the question is asking is a very cardinal question, and it's a question that it's not something that has not been observed. Your question shows a key gap. Perhaps the TB program in the past may have been targeting, for lack of better word, wrong people. But on the ground, when we do technical supervision on facilities, when we want to do technical support, it's also an observation that it's usually very difficult to interact with people who work in OPD. For example, they will talk about it's not my shift, or I'm knocking off. At one point, I've got a personal experience where the person in OPD literally walked out and left me alone in the OPD. So if anyone is here from the OPD, when people come to provide technical support, they're not there to judge you. They're not there to look for faults. It's actually an opportunity for you to interact with people who may be more experienced than you are and build the capacity in yourself. So I always encourage people that when the people are coming, you hear that is a technical support on the ground, get yourself involved, ask yourself a lot of questions. The other thing that some of you could do is, those of you are consistently logging into this platform and learning a lot, and observe that your colleagues within your district or within your facility are not consistent, or they miss out some of this knowledge. You could actually create an initiative at your own facility. Maybe you agree that on a monthly basis, our facility is going to meet and have a case discussion on TB, or clinical meeting on TB. You don't have to wait for the ministry to come. You can start this initiative on your own. We've visited some facilities and found initiatives that I've never seen before. I'll give you an example of one of my favorite initiatives that I found on the Copper Belt is in Mufulira, Chawama or something like that. What's that? There's a facility we visited sometime late last year in Mufulira. We were looking for the objective of the technical support was to look at gaps in case identification. But when we reached at this facility, it's like we couldn't find a single gap. They had come up with a new method of making sure that each person who passes through the facility has a chance to be screened for TB. So they blocked ways. So they had the deliberate pathway. So every patient who walks into the facility knew that I go here, next room is this one, next room is this one, next room is this one. So there was no chaos, rather to speak. You couldn't find people walking haphazard. It's like people knew, I'm starting from here, the next place is this one, the next place is this one, and everyone was on board. The pharmacy team was on board. In fact, the pharmacy team would not issue antibiotics until the patient produced evidence that they've left sputum or they've been screened for TB. So these are the only initiatives that the facility can take on your own. You don't have to wait for the ministry. When you've noticed a gap like this one, you can take it up yourself. I said, okay, if you are the SMS or you are the in charge somewhere, or you just walk to the SMS and say, look, I've seen this gap. I can interact with people who can assist us to do some training. They will train me. They will give you some. They can help me with material. I can train my colleagues here. We can have a monthly discussion. I make a presentation so that I also share the knowledge that I have with my colleagues. When you keep doing that, you're also training yourself at the same time. So you never forget yourself. So you become an expert. That's how some of us become experts. Not because I was born a TB expert. I became a TB expert because I kept teaching others. So I kept learning on my own and teaching others. So now I'm an expert. So you can also do that. It's not impossible. And again, don't always wait for the ministry to do the initiative. You can actually, before I go, one thing that you people don't realize is that the TB program is not at the ministry. Don't ever misunderstand this. The TB program is not at the ministry. The TB program is in your facility. You are the TB program. That chest clinic is the TB program. The people at the ministry are just there for logistical reasons, just to make things move. Without you people at the bottom there, for lack of better word, without you people at the facility, there's no TB program in the country. Okay, I've always said this, that it should be seen the other way around. You don't see the TB program the other way around. Don't start with the ministry, start with yourselves. As a TB program at your facility, what is it that you are doing? So this becomes a ripple effect. So they'll be felt at the national level. When you start from the facility level, your effort to be felt at the national level, and the country is going to move forward that way. So don't ever look at the ministry face. Always look at your facility and say, what can we do at our facility? These are the gaps that we've identified at our facility. How can we solve that? If you need technical advice, if you need technical support, then you reach out. Manager, Dr. Chitaro, Dr. Mput, we are thinking like this at our facility. How can you help us? Then people come in. These are the things that people want to hear. These are the things the minister wants to hear. These are the things the PS wants to hear, not the other way around. Over.
Great, thank you, Dr. Mputu. And yep, I guess that clears out certain things. So at the end of the day, TB program is owned by us individually, and I think we should be responsible for combating TB. And then I think we'll end by a last comment from Sandra. So Sandra, thanks. Sandra says, please, we need more trainings, even training practitioners, just not in the TB corner, but OPD, casualty, or even in the emergency room. And Sandra, I think people have seen that who may be relevant for training, and they have taken note. So it is 4:04 p.m. and I think today's been a very interesting session. A lot to learn from, a lot of clinical pearls that we've picked up. The network has been great. Thank you for all your contributions. Thank you for participating in all the poll questions. I think we've learned quite a lot today. And I would like to thank our panelists who are there today and contributed. And lastly, our presenter, Dr. Mputu, who always comes through for us and brings us this great knowledge. Thank you so much, Dr. Mputu. So at this point of time, I think we can call it a day. And thank you once again, and we'll see you next time on the HIV-TB Echo. Have a good day.